I can't see this far left side of the audience, so if we see. Okay, folks, my Timex says it's 1:30. And in respect for the time for our presenters, we're going to start on time. They have the lovely duty of following lunch, sort of like following the elephants in the parade. So this session is a non-parallel session, and we have 6 speakers, 1, 2, 3, 4, 5, 6, 7, 6 speakers in a video. I think you'll be entertained today. So I'm going to turn this. I'm Ken Sharp, by the way, from the Vanderbilt University. And my partner, Dr. Clancy Clark.
Hi, Clancy Clark from Wake Forest and pancreatic surgeon there at the Wake Forest University. We'll start with our first speaker, Dr. Blackley. This is titled Identifying Radiographic and Clinical Indicators to Reduce the Occurrence of Non-Therapeutic Laparotomy for Blunt Bowel and Mesenteric Injury. Dr. Blackley is coming from the University of South Alabama Medical Center.
Okay, mic's on.
Hello, everybody. First off, I just want to say thank you to SCSC for allowing me to present on this topic today. Speaking about radiographic and clinical indicators to reduce non-therapeutic laparotomies and blunt bowel and mesenteric injuries. So I have no relevant disclosures for this talk. So blunt bowel and mesenteric injuries are fairly rare and associated with blunt abdominal trauma, with an incidence rate reported to be anywhere from 1 to 5%. Most common cause and mechanisms are crush, burst, and shearing forces due to rapid deceleration. These injuries remain difficult to diagnose, particularly in the presence of hemodynamically stable patients, along with the findings of other intra-abdominal injuries that may obscure subtle findings such as mesenteric stranding or edema. Delays in diagnosis reported anywhere from greater than 24 hours to even as little as 8 hours is associated with increased morbidity and mortality in these patients. And uncertainty of these CT findings can often lead to negative or non-therapeutic laparotomies and efforts to prevent missed injuries. And despite the frequency of delayed or misdiagnosis of BBMI around the country, there is currently no universally accepted practice management guideline in the trauma literature. So the goal of this study was to determine whether there were certain combinations of CT and clinical findings that would allow us to better triage patients into operative versus non-operative pathways. So we retrospectively reviewed 1,098 patients from our trauma registry, all of whom were involved in an MVC. We took 8 CT findings that have been commonly associated with BBMI within the trauma literature, and their radiology reports were reviewed for documentation of these findings. In cases where hemoperitoneum and free fluid were not explicitly differentiated, the reviewer measured the Hounsfield units of the fluid. Anything greater than 20 was considered to be hemoperitoneum, and anything less was considered to be free fluid. Our outcomes measured included need for exploration, intraoperative findings, and the need for intervention, which we defined as the need for resection, ligation, or repair of vascular mesenteric or bowel injuries. So of these patients, 139 had at least one CT finding suggestive of BBMI. Of the 139 patients, there were a total of 38 who underwent operative exploration. However, I will state that not all 38 were taken specifically for findings of BBMI. Of the 38 patients who underwent exploration, 27 required intervention, and a total of 30 ended up having a confirmed finding of a BBMI. So for our relevant CT findings, we had a total of 4, hemoperitoneum without solid organ injury, pneumoperitoneum, active extravasation of contrast, and mesenteric stranding. Mesenteric stranding was by far the most common significant finding, whereas free fluid was the most common overall finding. However, this had no statistical significance. We had a total of 8 mortalities within this study, 5 of whom were managed with operative exploration at some point. Unfortunately, 2 of these mortalities were associated with delayed intervention. And in total, there were 8 laparotomies performed on patients who did not require intervention, whether they had blunt bowel mesenteric injuries or not. So our overall incidence in this study for BBMI was approximately 2.7%. We had a total of 4 CT findings that were statistically significant for need for operative intervention. Mesenteric stranding, however, being the most common significant finding, only about 1/3 of these patients total ended up having an operative intervention. And when you isolated out mesenteric stranding when seen alone without any other CT findings or in the absence of peritonitis, none of these required operative management. Isolated free fluid without other findings was in a total of 58 patients, none of which required operative exploration. So to kind of, circle back around, BBMI is a rare but challenging diagnosis in patients where CT findings are either unclear. Maintaining a high index of suspicion is very important, particularly for those who can't be reliably followed in a clinical manner. And repeat imaging or diagnostic laparoscopy should be heavily considered for patients who cannot be assessed for serial abdominal exams or those who do worsen clinically within the 24-hour period. And so from our study, we've concluded that when you have findings of hemoperitoneum without solid organ injury, active extravasation of contrast, pneumoperitoneum, or any findings in the presence of peritonitis, that should certainly lead you down a pathway to more heavily consider operative intervention. Whereas the findings of isolated small volume free fluid and mesenteric stranding, when you don't have peritonitis on exam, these patients can be managed conservatively with serial abdominal exams. And then followed and taken for operative exploration should they worsen clinically. And so by using this data, I don't know how well this can be read, but this was the clinical practice guideline that we kind of put together based on the results of this study for use at University of South Alabama. Well, thank you very much. I'll take any questions.
Great. We'll have Lindsay Perea from Lancaster General Hospital be our discussant.
All right. I would like to thank the Southeastern Surgical Congress for the opportunity to discuss this paper. And I would like to thank Dr. Blackley for the timely submission of this well-written manuscript. I applaud the authors for trying to answer this important question that I think many of us struggle with. The authors performed a study in an attempt to better elucidate predictive factors for blunt bowel and mesenteric injuries in patients following blunt abdominal trauma. Not only that, but they hope to determine which CT findings would possibly, in conjunction with clinical exam, predict the need for operative intervention. A missed bowel injury can lead to profound morbidity and even mortality in the already critically injured trauma patient. It is well known that CT, while widely used in the trauma workup, is not the best modality, as there isn't one in identifying hollow viscous injuries shortly after blunt trauma. Without the high sensitivity in identifying blunt bowel injuries, we often have to rely on the clinical exam to guide us, which can be difficult in the obtunded or otherwise distracted trauma patient. So I have a few questions for you. You define the population in this study of blunt abdominal trauma as those who were in an MVC and had a CAT scan performed. Was there any criteria that was more selective in this? For example, a seatbelt sign, abdominal pain, or tenderness on exam? If so, how many of the 1,098 patients had such findings? I ask, as we often know that a trauma patient gets pan scanned just because they end up in the trauma bay. Given that you said that there were 38 patients who went to the operating room for findings based off of CT scan, we noted that some of these had 2 or more findings on their CAT scan. So I'm wondering if your team considered running any further analysis to see if certain characteristics in conjunction with another had a more changed your sensitivity or specificity for injury. And how was urgent operative exploration defined? Was this directly from the trauma bay or emergency room? Or was there a time set at this? And of those that were done in a delayed fashion, how many and what changed the decision to take them to the operating room? You state that one should consider repeat CT scan or laparoscopy in 24 hours, but you also stated that there is an increased morbidity as soon as after 8 hours from injury. So if that's the case, why not perform a diagnostic laparoscopy on admission if there's any concern? I think a non-therapeutic laparoscopy is much better accepted than mortality due to overwhelming sepsis in these patients. And that's more of a rhetorical question, but
Yes,
great job. Thank you.
thank you. So to answer on the number of CT scan findings associated with the need for intervention, we do have the data organized in that manner. And we did do some playing around with analysis. We would like to have a much larger sample size before trying to, formally publish any sort of analysis regarding that. And but what we basically did find was that there was no significant correlation between the number of findings and the need for operative intervention in our smaller sample size. As far as patients who were taken to the OR in a delayed fashion, going back and reviewing, I define this as outside of the 24-hour mark, of which there were 4 patients who were taken, 2 of which, were these mortalities that I briefly discussed. And in one of those cases, the patient was severe ARDS, rhabdo, multiple orthopedic injuries on CRT, requiring, had to be proned. And so there was no way to accurately identify, abdominal exams or assess for, clinical worsening because they were in multi-system organ failure, essentially from hospital day 1. And what changed was essentially that they were not tolerating tube feeds, and they just, were acutely decompensating despite CRT. But, I believe his initial scan basically showed, he had severe chest trauma, solid organ injuries, but otherwise just a small amount of free fluid around the liver. One of the other patients who was taken outside of the 24-hour mark was actually a pediatric patient who was hemodynamically stable, had, I believe, like a grade 2 spleen and liver, was transferred to our children's hospital, and then had worsening abdominal tenderness and increased tachycardia. So they were taken after transfer by the pediatric surgeons. I can't speak to all four that were taken delayed, but the 2 mortalities were taken, I believe, on hospital days 4 and hospital days 8. Let's see. So I agree with you as far as, diagnostic laparoscopy. I think that is an excellent tool with a very low, complication risk. When you look at a negative diagnostic laparoscopy compared to a negative exploratory laparotomy, it's associated with a shorter hospital stay, lower hospital costs. And in a lot of patients, I think this is a very reasonable thing to do. The time that I think personally that I would consider rescanning first would be in patients who have very elderly patients, those who don't have a lot of cardiac reserve, or people with severe chest trauma. If you've got concern for whether they're going to tolerate pneumoperitoneum and insufflation, then those would be the ones I would consider maybe scanning with oral contrast first.
Quick question, Dr. Collins.
Yeah, Jay Collins, Norfolk, Virginia. Very nice presentation. What did the 2 patients die from? Was it sepsis and a blunt hollow viscous injury? And what should you have done differently? Because obviously that's devastating and you can't miss that. The other question you will real quick, you recommend maybe laparoscopy or CT scanning when you're undetermined. What are you going to look to find on a CT scan that's going to really keep you out of the abdomen? Because I would argue this patient population, you really need some kind of exploration and maybe preferably laparoscopy.
As far as what would have done differently for our 2 patients, it's it's a tough one because both of these patients had very significant injuries outside of the abdomen as well. Neither one could be followed with clinical exams. And in the other patient's mortality, there was, you never want to, being able to read your own trauma scans is very important in trusting your own gut in reading them. And in one case, there was an addendum to a radiology report. So there was a little bit of confusion for what what they were originally calling a low-grade liver injury. But in reality, on the rescan, it was active extravasation from a transverse mesocolon hematoma. And so, hindsight is 2020, but that's a situation where
Time.
I would have taken that patient to the operating room on admission rather than waiting.
Thank you so much.
Okay, our next paper is EFAST lung view versus chest X-ray in trauma patients. Are chest radiographs necessary? By Doctors Deloche, Reif, Smedley, Klutz, Baharavu, and Kalkworth from the University of Arkansas.
All right. Thank you very much. Everybody hear me? Perfect. All right, perfect. So again, I'm Joe Deloach. I'm a general surgery resident at the University of Arkansas. I will be talking about chest X-ray versus ultrasound. Which one is more accurate in predicting a pneumothorax or need for a chest tube in these trauma patients? Quickly, this disclosure, we did have some internal funding for our research. And also quickly, just want to thank the conference for having me, and then my mentor, Dr. Kalkworth, and some of the residents who supported me throughout this. So jumping right into it. So a little bit of background. We know that the gold standard for diagnosing a pneumothorax is a CT scan in trauma patients, right? But there are some issues with it. One, namely, it takes a long time. Relatively, it costs some money and exposes patients to radiation. So historically, what have we done? Well, to do it fast, you just get a chest X-ray. And that is historically the quick way to see if a patient has a pneumothorax. But there's a paradigm shift really over the past couple decades that would suggest that ultrasound is actually more accurate in diagnosing a pneumothorax in trauma patients. So our purpose of this study then was to look at the ability of chest X-ray and ultrasound, and even a combination of both for not only diagnosing pneumothoraces, but also based on the size of pneumothorax. And so, okay, what did we do? For our methods, it was a retrospective review. We looked at data from 2021. We pulled data from our institution's trauma registry. We included adults 17 years older who had an ultrasound chest view. And then we also pulled data for chest X-ray, for CT scans, and then we determined chest tubes based on procedure notes in the EMR. We excluded patients who didn't have a CT scan within the first 2 hours because those patients often went to the OR. We excluded patients who didn't have a chest X-ray within the first hour, and we excluded patients who had a chest tube already present on their initial chest X-ray. Oftentimes patients were transferred in with chest tubes already. So analysis, so what did we do? We looked at pneumothorax detection on chest X-ray and ultrasound compared to the gold standard, so CT. And in another group, we looked at pneumothorax detection on chest X-ray and ultrasound compared to chest tubes placed. And then in a sub-analysis, we looked at positive pneumothoraces on both imaging modalities based on size on a CT scan. A little on our demographics here, you can see our age was on the younger side in the 40s, predominantly male. The numbers here in the middle are all comers. So 20% of all comers in this study had pneumothorax on CT scan, 3 for chest X-ray, 7 for EFAST. Our mechanism of injury in this population was predominantly blunt, 93% and just 7% penetrating. And jumping into some of our data here. So in the top left, you can see chest X-ray detected on pneumothorax compared to CT scan. So out of these 82 patients, 17 had a positive pneumothorax on chest X-ray. So that gave us a sensitivity of 20.7%. You can see the specificity was quite high, nearing 100%. In the middle portion of this table here, we compared based on size. So a pneumothorax that was read as a large pneumothorax on CT scan by a radiologist. You can see out of 17 of those, 4 were seen on chest X-ray. And then in the bottom here, we compared to chest tubes placed. So out of those 25 patients, 10 were detected on chest X-ray. And so we did the same thing with ultrasound. Then you can see briefly for the second time, our sensitivity is 33% when comparing to pneumothorax on CT scan. And then for large pneumothoraces is better, 53%. And for patients who had chest tubes placed, again, 53%. So then we took it one step further and compared either a positive EFAST or positive chest X-ray. And when compared to CT scans, it caught about 40% of them. When classified as a large pneumothorax, 57%, and for predicting a chest tube in the first 24 hours, 64%. So at our institution, we showed that ultrasound had a higher sensitivity than chest radiograph for both detecting pneumothoraces and placing chest tubes. But, when looking through the data, we saw obviously our sensitivities were quite low. When you look at the body of literature as a whole, though, even as early as the early 90s, the range of sensitivities that have been reported have been as low as in the 20s and as high as in the 90%. So while ours are quite low, they're within the reported range. This last bullet point here, why specificity matters. So some authors have argued that ultrasound should actually be used for its specificity rather than sensitivity, because often in the trauma bay, you're trying to rule out pathology rather than say, hey, that's a pneumothorax. It's just as useful to be able to rule it out and move on to the next thing on your differential. So in conclusion, the body of literature as a whole would agree that ultrasound is superior to chest X-ray in detecting pneumothorax. Our data aligns with this well, but as mentioned, we have lower sensitivity than most of the reported literature and quite high specificity. And so for kind of a take-home point here, we would caution the use of any of these data exclusively to treat trauma patients, but we would encourage everybody at your own institution to look into your numbers to see where they lie within the range that's been reported on already, because it may change from institution to institution. Thank you.
Our discussant is Dr. Jay Collins from Eastern Virginia Medical School. And Jay, I believe I remember Dr. Rebecca Britt presenting data on this topic several years ago at this meeting.
I think that would be true. Thank you, Dr. Sharp and Dr. Clark, for the Southeastern Surgical Congress for allowing me to discuss this paper. Again, very nice presentation, Dr. Deloach. Again, topic very much interested in. At our institution, we've kind of abandoned chest X-rays in the trauma bay for a lot of blunt trauma and really rely a lot on ultrasound. So it is somewhat discouraging to see that, ultrasound is not as sensitive as many maybe of us hope that it is. I have several questions for you. So in the trauma bay, who is doing the interpretation of the chest X-ray and the ultrasound? What kind of training do these folks have? And then how many views are you getting of the chest? Sometimes it takes a couple of different views to get a good idea. And then why did you choose to exclude patients with indeterminate ultrasounds? We all know it's a study that's very operator dependent. Patients who are maybe morbidly obese have a lot of subcutaneous air. It's just hard to get a window. And that's obviously gonna, a limitation of the technique, but is this gonna lower your sensitivity even more, unfortunately. Then when was the chest tube placed? Was this done in the trauma bay before they went to the CAT scanner? And if it was, did you correlate the findings with ultrasound or chest x-ray with physical exam? Because I will argue for most of us, it's not just a picture that you're looking at, but is the patient tachycardic, hypotensive? What are their O2 saturations? Do they have diminished breath sounds on one side? You know, this is not just an ultrasound decision. It's really a clinical decision, whether or not you're going to get a chest x-ray emergently or ultrasound, because obviously we don't want to take somebody to the CAT scanner who's got a real large pneumothorax who's, hypoxic. Then the other question, why do you think your sensitivity with ultrasound and chest, especially chest x-ray, is so low compared to a lot of other studies? And I would argue, especially with the large or moderate pneumothoraces, the small ones are hard to see, but if you have a big pneumothorax, I would hope we're picking that up any better. And then one more that's just maybe going to ask some speculation along these lines. Have you thought about using the same study looking for pleural effusions of hemothorax? Maybe this could be another, study for you to look at, come back next year and, see what our sensitivity is looking for fluid. But again, very nice presentation and look forward to your answers.
Thank you. So for your first and fourth question, I'll actually combine, if that's okay. First question was who's doing the interpretation and how many views did we get? And your fourth question was why is our sensitivity so low? So I think these may be linked. As I mentioned, the sensitivity range is as low as in the 20% to 90% in the reported literature, but I think it varies based on institution. At our institution, we have sometimes new residents performing our EFAST exams. We don't have the same probes or same ultrasound. We have 3 or 4 different ultrasound machines that are all different. And then also it often depends on who the staff is, but it's being read by the surgeon on call or the ER attending on call that night. And so there's a lot of heterogeneity there and a lot of places where you could have many variables. And so I think that probably adds to our low sensitivity. In addition to that, these official reads are based on who's on call for radiology also. And so it's not standardized at all. Our radiologists do define pneumothoraces in a couple ways. So we call it a small pneumothorax, less than 20%. A moderate pneumothorax is 20 to 50%, and a large pneumothorax is greater than 50%. So greater than 50%, that's quite large. And I think it's probably larger than some of the reported literature. Some of the reported literature just says that there's a high predictive value for just greater than 35 millimeters. So greater than 50% is quite large. So ultimately, I think there's a lot of variables that are difficult to standardize, especially in a retrospective study. And so I think that adds to our low sensitivity. You asked when were chest tubes placed. Most of our chest tubes in these patients were placed in the trauma bay, although we included patients who had tubes placed within the first 24 hours. And then in terms of looking for pleural effusions, we didn't think about that for this study, but I think that's a really interesting question, and we could adapt this data to that to look at that in the future.
Dr. Franklin.
Yeah, Glenn Franklin, Louisville. I applaud your efforts to try and reduce ionizing radiation on our trauma patients. I've thought my entire career that we would eventually just scan someone in some magic way, like on Star Trek, from head to toe, and it would tell us all the diagnoses. I criticize the residents for sending the patients to the circle of knowledge all the time, CAT scan, to diagnose some things. But having said that, it is the world that we live in. And so I looked up your numbers for Arkansas while you were presenting, because there was a small point in the discussion questions about the ones you eliminated that I find somewhat distressing. Obesity. I'm from Kentucky. We are number uno in obesity nationwide. You're from Arkansas. You are number 34. I was just wondering if there would be a way to stratify your data against BMI, because I suspect that those patients who are indeterminate, or maybe some of your sensitivity and specificity issues should rule out if a patient is over a certain BMI. Although I appreciate your transparency about the heterogeneity of residents, attendings, radiologists, even 4 different ultrasound machines, which that was a good little toss in for people who are not facile with it. Every machine and every probe's a little different. And so I just was wondering your thoughts about that.
Yeah, absolutely. Not much time, but we did think about BMI. Obviously that in Arkansas, we have larger BMIs. And so that did come with the data that we extrapolated from our trauma registry. And so going forward, I think that's going to be a big point to look at to see if when we look at our indeterminate numbers, if you would think that it would be with people with bigger BMI. So that is data that we have extrapolated. We just haven't applied it. So I think that would be good to look at going forward.
Very quick, final question.
2 questions. One. Okay. Oh shit. How did you decide to put in how did you determine to put a chest tube in or not? Was that based on attending preference? Did you use the 35 millimeter rule?
We did not use the 35 millimeter rule. As Dr. Collins mentioned, it was a clinical decision. It often depended on who the attending was that night, because some attendings are comfortable putting one in sooner than others. Some, so it just depends.
That's the answer. It depends.
Yeah. Yes, sir. Thank you.
Okay, I'm a little OCD over keeping on time, so live with it.
All right.
We in Nashville call it the answer machine, or the answering machine, when they're sent to the circle of life.
We're going to move on to a video presentation by Melissa Tobadai from Advent Health Tampa. Her video is titled Robotic Systematic Portal Lymphadenectomy, Description of Surgical Technique.
Good afternoon. My name is Melissa Tawadi. I am an undergraduate student at the University of South Florida, currently interning at the Digestive Health Institute with Dr. Sukandi. Today, I'll be presenting a robotic lymphodectomy. We had a 71-year-old patient who presented with gallbladder cancer. The CT scan showed a 4.3 centimeter mass in the fundus of the gallbladder. The plan was to undergo a robotic radical cholecystectomy, a partial hepatectomy of segments 4 and 5, as well as a systemic lymphodectomy, which we will be focusing on in this video. So we can see that the gallbladder and portions of segments 4 and 5 are being retrieved already. This is the Tokyo classification of the lymph nodes in the abdomen, the porta hepatis, as well as the retroperitoneal lesion. We will be referring to this diagram throughout the video. So first, we started by dissecting the hepatogastric ligament, and then went through the lymph tissue through through the curvatures of the stomach. This was one of the lymph nodes removed from station number 7. This is another lymph node that was removed from station number 11. Right here, we are removing the lymph nodes from the hepatic artery. These were labeled as station number 8. We use hook cautery and vessel sealers for this step. This is another lymph node from the 12B region by the bile duct. Next, we move to the lymphatic channels by the hepatoduodenal region ligament by using hook cautery and vessel sealers as well. We use clamps to avoid lymphatic drainage. Leaking, excuse me. Next, we are skeletonizing the right and left hepatic arteries. This is the ICG that was injected about 45 minutes before getting into this step in order to see if there's any potential abatement bile duct. This was one of the lymph nodes between the bile duct and the common hepatic artery. Over here, we are removing the cystic duct. We try to get as close to the bile duct as we can. The specimen was then sent to pathology and came back with negative margins. This was another one of the lymph nodes from the 12B region that moved earlier, so we weren't able to catch it until now. Now we use vessel sealers and biofluid forceps for this specific lymph node. So all of the lymph nodes were placed in a catch bag, retrieved, and sent to pathology for analysis. So the patient did well. Pathology report showed a PT1, BN0, M0, G1, well-differentiated adenocarcinoma. There was a total of 18 lymph nodes removed. None of them showed any sign of tumor invasion. The patient was discharged on postoperative day 3. Thank you very much for listening, and thanks for the opportunity to speak. I'll be happy to answer any questions.
Thank you so much. We do not have a discussant. There's no discussant. If anyone has any questions.
What was the little blue thing down in the 7 o'clock position on the view? It looked like a ligature or something. You
Well,
know, okay.
I'll let Dr. Spondy answer that.
Swatus Kandi from Tampa. Thank you for the very precise observation of this video. So basically, a part of the operation that we did not show here is the duodenal cochlearization. So in order to get to the area behind the bile duct, we always cochlearize the duodenum. So then we can flip the porta hepatis. So then the retroportal lymph node now is facing us. We have a little bit of bovine injury touching the duodenum, so we just oversaw the area with robotic.
Just a
polypropylene
little
sutures.
duodenal injury. Okay, good.
Thank you.
Thanks for your time.
Any other questions from the audience? Okay.
Great. Thank you so much.
Okay, our next presentation, minimally invasive approach may mitigate the negative impact of smoking in patients undergoing liver resection history. Analysis of clinical outcomes from a tertiary hepatobiliary center presented by Dr. Sukandi, Drs. Ross, Patel, App, Ignatius, Siblis, Crespo, and Dr. Alex Rosemurky.
Sound like you know him.
Oh, yeah.
Good afternoon, everyone. My name is Vince Butano. I'm the minimally invasive fellow here at Advent Health Tampa. I'll be presenting our paper on the impact of smoking history and outcomes after a robotic hepatectomy. Robotic hepatectomies are becoming more commonplace nowadays. Next slide's going. The literature on this is lacking, to say the least.
Closer.
Yes, sir. The literature on robotics liver surgery is lacking at this point, specifically regarding postoperative outcomes. Smoking has been long shown to be a predictor of poor postoperative outcomes on many types of surgery. Usually it's postoperative wound healing or pulmonary postoperative pulmonary complications. We undertook this study to see if those claims still held true after robotic hepatectomy. We have a large volume center, so we followed 353 patients. We had 125 smokers and 228 non-smokers. We defined smokers as anybody with any smoking history. It's very difficult to get any specific numbers out of the patients. We then did propensity score matching and identified about 70 patients in each group. Then we further dissected it down and broke it down by using the Awadi scores for difficulty. So as you can see here, the difficulty is based on essentially segment of the liver as well as liver function and previous operations. Here are our results. So these are our results pre-operative or before matching. And you can see here that's statistically significant for age and sex, as well as MELD and cirrhosis, which is unsurprising. And then again, before matching, you have the complications that we've all seen before. And postoperative pulmonary complications all reduced to almost none after we matched the groups, which we were pleasantly surprised by. And then we went a little bit further and did a Kaplan-Meier survival curve. And again, the smokers were seen to have a lower survival after several years, but not significant in any way. And then in conclusion, we have no significant difference after matching in these patients. I don't want to jump the gun and say that, robotics mitigates all the effects of smoking, but it certainly does decrease postoperative pain, which improves pulmonary toileting and therefore could mitigate some of the risk factors from long-term smokers, which is a high subset of our groups in HCC. Thank you, and I'll take any questions.
Thank you. Our invited discussant is Dr. Jim McLaughlin from Knoxville, Tennessee.
All right, good afternoon, and appreciate this topic and the presentation. I guess most of my questions are really related to the definition of a smoker. And there's several nuances that just to clarify. One is, how did you determine what a former smoker was? Meaning that if they said they smoked 30 years ago, did you still include them versus 6 months ago, 3 months ago, or pack years for those that are actively smoking? So really all that to say, how did that definition come about? Did you all encourage smoking cessation? Meaning, was there a program in place to encourage smoking cessation? And if so, how do those folks that did stop, how was their outcome impacted? And then really last question is just related to the impact of blood loss. At least the data that you had sent me, and I appreciate you sending that manuscript. The intraoperative blood loss was very low in the almost into the double digits rather than triple digit CCs. And at least in liver surgery, a lot of literature is based on blood loss related to complications, and how much in multivariate analysis did the low blood loss contribute to relatively good outcomes. Thank you.
Thank you, Dr. McLaughlin. I noticed that you trained across the street at Moffitt. So as for your first question on how we define smokers, it was any patient that came to the doors that said they smoked in the past. Due to the difficulties in defining how much, quantifying how much they were smoked, we just grouped them all as smokers. We didn't break it down any further. The second question, yeah, we did and still do encourage smoking cessation. We refer all smokers or smokers and previous smokers to pulmonology preoperatively for evaluation. And we did have about an 80% smoking cessation preoperatively. We didn't break it down to see if those patients had any different outcomes though. Regarding the blood loss, that's an excellent point. Our blood loss is traditionally very low, and we did have a lot of smaller liver resections that basically we didn't dissect out the middle or right hepatic veins or anything, and we just did kind of a wedge resection, and those always traditionally have pretty low EBL. But given the excellence of the intraoperative ultrasound and the vessel sealer, we generally have pretty low blood loss. But that definitely is a good point that it may be part of the reason we had such good outcomes. I think it's more multifactorial. And then,
I'm sorry.
no, I was just trying to remember the last one. I think it's
Major blood loss was his last question.
yeah, okay.
Dr. Richards.
Yeah, Bill Richards from Mobile. I enjoyed your presentation, but I reject your conclusions. You only had 70 patients, matched patients in each size. So you've got a classic, you don't have enough power to determine. And you said the difference was 6% versus 2%, what I saw flash across the screen. So I would say, don't smoke before you're undergoing surgery. Smoking is bad for surgical patients. I'm sorry, I reject your conclusion that you can do robotic surgery in smokers.
Point is well taken.
Nice answer.
I like this
Good.
group. Thank you.
Yeah, I think that's a significant problem with the numbers and there are smokers and there are smokers. I asked one of my patients the other day, do you smoke? He said, yes. I said, do you smoke regularly? Yes. How much? I have a cigar 3 times a year. He would have been a smoker in your.
Yeah, exactly. It's when trying to quantify these smokers out, it's nearly impossible because some people say they only smoked a little bit and they smoke 2 packs a day.
Right. Okay. Thank you.
Thank you.
Okay, our next speaker is Treasure Bright, who will be presenting impact of fluid balance on intensive care unit length of stay in critically ill trauma patients. This will be from University of Florida College of Medicine in Jacksonville.
All right, thank you for that introduction. All right, so I don't have anything to disclose in regards to this presentation, nor do any of my co-investigators. All right, so the type and amount of resuscitative fluids that are used in the trauma bay have been heavily studied over the past several decades. And while much of the trauma resuscitation literature has been focused on optimal blood product ratios, there is data to suggest that large volumes of crystalloid in resuscitation can increase morbidity and mortality in these patients. Accordingly, the Advanced Trauma Life Support Guidelines did recommend in their 10th edition, no more than 1 liter of crystalloid in the initial trauma resuscitation period. And from that development, you can also see things like the ROSE methodology, which came about to kind of influence these patient outcomes. Additionally, determining correlations between a positive volume balance and the total ICU days may provide data to either support or refute the development of deresuscitation protocols. So the primary outcome of my study was to determine the association of a positive volume balance in critically ill trauma patients at 72 hours. This was focused on their total ICU length of stay. So my study design was a single center retrospective observational study conducted at UF Health Jacksonville in Northeast Florida. My study spanned over a 2.5-year period, and patients were collected from a trauma data registry as well as our EHR for data collection. So adults that survived greater than 48 hours and were admitted to the trauma service directly from the OR or from the emergency department were included in the study. And on the screen, you can also see several of our exclusion criteria to be included in the study. So my study design looked at overall fluid balance, which was expressed as a total percentage of the patient's body weight. And we grouped patients into 3 groups. So negative fluid balance, even fluid balance, and then a positive fluid balance. For our study outcome, again, our primary outcome was the ICU length of stay. Secondary outcomes we looked at did include the overall hospital length of stay, ventilator-free days, incidence of compartment syndrome, need of renal replacement therapy, and overall vasopressor hours. All the statistical analyses are on the screen. Of note, I did do a multiple linear regression looking at 6 different endpoints, as well as a post hoc analysis looking at blunt injuries. So I screened a little over 700 patients, included 250 of those, and you can see the breakdown of the inclusion criteria in those 3 volume balance groups that I mentioned. Additionally, on the right-hand side of the screen, you can see the most common reasons that I excluded patients in our study. So for baseline characteristics, the ones that were significant in our particular study were age. So patients in the positive volume balance group were the youngest, and they also weighed the less out of all of the participants. For injury characteristics, you can see the difference in mechanism of injury, so blunt versus penetrating against all 3 fluid balance groups. Additionally, you can see their FAST exam and their injury severity score, as well as GCS and Charlson Comorbidity Index, taking of note the ones that are statistically significant in our study. Next, I've listed the vitals and parameters. These are the vitals and parameters that were first collected on admission to the trauma bay. Nothing that was captured after that was included in the study, just those first initial values. Of note, you can see that lactate was the highest on admission for our positive volume balance group, as well as a systolic blood pressure being the lowest in that group, both of which were statistically significant. And next, you can see some additional support, as I mentioned earlier. So this looks at IV diuretic administration, hours of vasopressor therapy, and then of note, we did classify respiratory device, respiratory support in 4 separate groups. There we go. All right, so for my primary outcome, as a reminder, it was total ICU length of stay. And as you can see, patients in the positive volume group did have a statistically significant longer volume or ICU length of stay in that volume balance group. Next, we have the overall hospital length of stay, again, which was statistically significant to be longer for the patients in the positive volume balance group compared to those in the net negative volume balance group. Looking at the secondary outcomes, you can see development of ARDS or acute respiratory distress syndrome was statistically significant in the positive volume balance group. And this is the multiple regression that I talked about. And you can see here, looking at the beta as well as that p-value ratio, that the ventilator-free days as well as net fluid balance at 72 hours were statistically significant to overall impact our primary outcome. So in conclusion, we found that a negative volume balance at 72 hours did have a significant decrease in the total ICU length of stay in our patients admitted. So for clinical implications, so one could consider a more conservative fluid balance strategy in this patient group, but really further studies are kind of needed to evaluate further deresuscitation protocols. Thank you, and I'll take any questions.
Thank you. We'll invite Dr. Burns to discuss this paper from East Tennessee State University.
Good afternoon. I'd like to thank the Southeastern Surgical Congress and the moderators for the privilege of discussing this paper. I appreciate the author submitting a timely and well-written as well as thought-provoking manuscript. I would expect nothing less because I used to work there, right? So that's my full disclosure. So my first question has to do with the paper was based on weight, and I find that an interesting way to track fluid balance. In particular, I'm curious as to when that weight was obtained and was that consistently obtained on patients? Was that done in the trauma bay or on arrival in the ICU? I think certainly we all have seen the challenges of trying to follow I's and O's despite seamless electronic medical records. I can't get operative data into our I&O flow sheet without a nurse manually extracting it and putting it back in. So a novel concept, but certainly curious as to where the weight came from. My second question is why 76 hours? In the manuscript, it talked about the fabled autodiuresis. Was that the thought process for picking 76 hours? And did the data hold at 24 and 48 hours? Because it looked like there was potentially up to another 190 patients that could have been included. My last question comes from what was asked of me when I presented my first paper at the research conference at the University of Florida in Jacksonville. And my senior partner, my mentor, an iconic legend surgeon from UF Jax, Rick Freiberg, turned to me and said, "So what?" I am going to attempt to ask you that question in a much kinder and gentler fashion. So the patients that were in the fluid overload group appeared to be younger, were more likely to have a penetrating injury, a trip to the operating room, and a higher ISS. So are we looking at a implicit bias in that these patients were already more severely injured, which kind of put them in that group to begin with? Or is this something that I should take a paradigm shift back to Northeast Tennessee with me with my luggage tomorrow? Thank you again.
All right. All right, so the first question was about weight and how we expressed fluid balance as a percentage of the patient's baseline weight. And this was actually not a novel concept that we developed. This is actually from another study. Balakumar and colleagues actually did a paper that classified patients based on their positive fluid balance, net negative or net even, as a respect to their weight. And so we kind of took that from their study and wanted to kind of incorporate that, because if a patient is, a few liters positive, it's really important to kind of assess like how positive they are in regards to their overall body habitus and their weight. The weight was the first weight that was charted in the patient's EHR, whether that be in the trauma bay or in the ICU. That was the weight that I used to kind of calculate their overall fluid balance. The next question was, why did we choose 72 hours? So when I was going through and doing all of the statistics myself, I actually did do 24, 48, 72, and 96 hours. The significance or the statistically significant endpoint for ICU length of stay did not hold true at 24 hours, but at 48 and 96 hours, you can still see the statistically significant difference. We chose 72 hours because that's sometimes when patients are not returning to the OR as frequently, and it's thought that maybe we could start de-resuscitating those patients, start taking some of those maintenance IV fluids off, things like that. Not for all patients, but just for some of them. So that's why our team kind of agreed on that 72-hour mark. The next question was the so what question. And I think from this paper, and really a lot of the new studies that have come out about fluid balance in general and just fluid volume and the types of fluids to use, I think it's really important to consider that in certain patient populations, maybe not those young penetrating injury patients that are returning to the OR that are getting a lot of blood product resuscitation, but for the other two groups, maybe we could consider a more strict volume resuscitation in that initial trauma bay period. Additionally, a lot of institutions across the country have started to develop protocols for de-resuscitation, whether that be canceling maintenance IV fluids, double concentrating pressors, trying to get volume out of drugs, for example, or even developing de-resuscitation protocols that involve diuretics. So administration of IV diuretics for those patients once they've kind of stabilized a little, if you will. And then the last question was the question about the more severely injured patients. And so that is a question that I have gotten before. As I mentioned, I did do a post hoc analysis looking at patients that were specifically in that blunt injury group, because that's usually the question I get when presenting this research. And the significant endpoint for ICU length of stay was also statistically significant when looking at that post hoc analysis. It's hard to kind of extrapolate this data for those much more sick patients. So the younger penetrating injury patients. And I think that's kind of why, if you're looking at outcomes from this paper or looking for like what to do with this information, maybe kind of carving off that group and maybe not considering them and just doing further studies in that particular group, looking at maybe those sicker patients or more critically ill patients.
Thank you.
Mark Hamill from University of Nebraska. Interesting paper, and I think anyone who has gray hair who's resuscitated trauma patients for a while remembers what would happen when you would give these patients liters and liters and liters when they came in and how badly they do. My question is, again, and it parallels what he says, you're looking at your ISS, your one group was in a moderate injury range, ranging to kind of a serious, the upper end of the serious injury range. So looking at them as groups might not be the right answer. Did you consider doing any matching or anything like that, looking at patients with similar injuries who got different fluid and seeing that might give you some more robust data?
That is not something we discussed initially when doing kind of the IRB approval and things like that. But that is something, looking back, that we would have liked to have done, just because when we started to tease out the data and start to get some of those endpoints, you can really see that that positive group was essentially the most severely ill group. But that is a great consideration moving forward for the project.
Any other questions? I have a short question. I mean, one of the things that, and I totally agree. I remember the days of saltwater drowning quite vividly. I think I think admission blood pressure would have been interesting to know. I mean, how many of these people appeared in shock? Because the more severely injured group had a much higher lactate. And I feel like there's some multivariate confusion here.
Mm-hmm. Yes, the systolic blood pressure on admission was captured, and it was lower for the positive fluid balance group. So that does kind of play into that injury severity score, as well as just the overall volume that they did receive.
Great job. I just wanted to make one comment that you divide into 3 groups and you had 250 patients. Did you consider lumping the normo and the low resuscitated patients? So you got only 2 groups, because there's a lot of statistical challenges when you have 3 groups and only 250 patients.
Yes, that was something that we considered in the very early stages of this project, just doing a net positive and just a net negative. So cutting off at 0, anyone above 0 being in that positive group. The only thing that we had an issue with is we didn't want to classify somebody that was only 2% positive, the same as 12% positive. And so we wanted to kind of capture that like middle of the road, if you will, volume balance versus somebody who was much more higher in their overall volume balance. So that's kind of why we did the 3 groups.
What about just using as a continuous variable?
Due to the project in itself, that is not something that we considered.
Okay, thank you. Great job.
Thank you.
Thank you. Our next presentation, your zip code matters. I guess this is the Beverly Hills 90101 or whatever it was. Influence of neighborhood location on outcomes in older adults undergoing emergency general surgery procedures, from the University of Maryland, with the authors of Naim, Dylan, Kufera, and Dr. Jose Diaz, who I believe now is of Tampa.
Yes, he is. Thank you for giving us the opportunity to present. We have no disclosures. So social determinants of health are those environmental factors that can impact health and healthcare outcomes. Examples of social determinants of health include economic stability, education access and quality, healthcare access and quality, the social and/or community context, socioeconomic status, and finally, an individual's neighborhood or built environment. These social determinants of health can impact certain surgical outcomes, such as postoperative mortality, complications, length of stay, and failure to rescue. Now, the neighborhood and built environment, which is one social determinant of health, comprises of all the physical elements where an individual lives and works, including homes, buildings, streets, open spaces, and infrastructure. The neighborhood and built environment are closely related to a patient's socioeconomic environment, and has been shown to correlate with health outcomes, including diabetes, cardiovascular disease, and obesity. Now, switching gears a little bit, older adults represent the fastest growing population within the United States, and many require emergency general surgery procedures. Older adults have an increased risk of morbidity and mortality due to age, comorbidities, and frailty. The influence and interplay of social determinants of health on outcomes among older adults after emergency general surgery procedures is unknown. Variations in the neighborhood, built environment, and socioeconomic status may influence surgical outcomes in this vulnerable patient population. The aim of the study was to determine if zip code, serving as a surrogate for the neighborhood, built environment, and socioeconomic status, influences outcomes with respect to in-hospital mortality and discharge disposition in older adults undergoing emergency general surgery procedures. We hypothesized that older adults who reside in less affluent areas would have an increased risk of in-hospital mortality and an increased risk of discharge to a higher level of care after emergency general surgery procedures. We reviewed hospital encounters from 2008 to 2019 for older adults undergoing one of the following emergency general surgery procedures, including appendectomy, cholecystectomy, partial colectomy, small bowel resection, lysis of adhesions, surgical management of peptic ulcer disease, and laparotomy. Encounters reviewed came from the Maryland State Health Services Cost Review Commission database. The database provides information regarding patient demographics, payer source, severity of illness, procedures, and complications. We correlated zip code with the median annual income and identified the 50 most affluent neighborhoods, which we will call here MAN, and the 50 least affluent neighborhoods LAN based on the median household income. Data examined included patient demographics, disease severity, clinical characteristics, procedures, hospital discharge, payer status, and our outcomes include hospital length of stay, ICU length of stay, postoperative complications, in-hospital mortality, and discharge disposition. Our primary outcome was in-hospital mortality and discharge to a facility with a higher level of care. We used bivariate analysis and regression models, and a p-value of less than 0.05 was considered statistically significant. So our results are as follows. There were 8,661 patients identified over the 12-year study period. 27.3% belonged to the most affluent neighborhoods, while the remaining 72.7% belonged to less affluent neighborhoods. Compared to individuals belonging to the most affluent neighborhoods, those coming from the least affluent neighborhoods were less likely to be male, more likely to be Black, more likely to have a higher all patient refined severity of index and risk of mortality, higher Charlson comorbidity indices, more likely to be admitted to a smaller hospital and to be covered by Medicare. Appendectomies, cholecystectomies were more frequent in patients belonging to more affluent neighborhoods, while partial colectomies, small bowel resection, and laparotomies were more likely to occur in patients belonging to lesser affluent neighborhoods. With respect to unadjusted outcomes, patients belonging to the least affluent neighborhoods had prolonged hospital and ICU lengths of stay, more complications, a higher mortality, and were more likely to be discharged to a facility with a higher level of care. We next identified factors associated with in-hospital mortality. These included increasing age, non-white race, increasing Charlson comorbidity index, increasing hospital size, and residing in a less affluent neighborhood. Similarly, we identified factors associated with discharge to a facility with a higher level of care. These included increasing age, non-white race, increasing Charlson comorbidity index, and residing in a less affluent neighborhood. Limitations of the study include utilization of an administrative database where elements may have been either miscoded or undercoded. We were unable to examine the contribution of more granular data, such as time to intervention, which patients were transferred to another facility, and so on. Also, we can't apply these findings to other geographic areas since this was a single state database. In conclusion, when we use zip code as a surrogate for socioeconomic status, neighborhood, and the built environment, we saw that older adults from less affluent neighborhoods had an increased risk of in-hospital mortality and were more likely to be discharged to a higher level of care. Neighborhood residents and location are important to social determinants of health. Simply stated, where you live matters. It is imperative to recognize where patients reside before we can make a bigger impact. Thank you. I'll take any questions.
Thank you. Our discussant is Dr. Michael Mardiak from EVMS.
I'd like to thank the Southeastern Surgical Congress for the invitation to discuss this paper. I'd like to congratulate Dr. Dillon for an excellent presentation and the authors for a superb manuscript, and thank them for providing it in a timely manner. Their work is an important addition to the growing body of literature addressing disparities to access to quality care. By using zip codes as a surrogate for socioeconomic status, they demonstrate that older patients in less affluent regions in the state of Maryland suffer worse outcomes, but I do suspect that this is probably consistent in other states. I have a few questions. Did you look at what setting the zip codes represented? Was this rural, urban, or suburban, and the breakdown for each group? Did the less affluent neighborhoods represent a higher incidence of urban or rural setting? And if rural, did the distance to a medical center have any effect on outcome and delays in presentation? For the more affluent neighborhood, you had a higher proportion of appendectomies and cholecystectomies seen. And in the less affluent group, you saw more partial colectomies and small bowel resections. Did you look at the outcomes by procedure? And also, did you look at the surgical approach, minimally invasive versus open approaches for each group? And then lastly, you categorize nicely the hospitals by size, but did you look at the effect if they had an acute care surgery service at that hospital where they presented? I'd like to thank again the Southeastern Surgical Congress and congratulate the team on their great work.
Thank you for the questions, Dr. Martiak. So for the first question, we did not look at the types of areas that these zip codes corresponded to because the intention of the study was to establish that there was a discrepancy. However, it certainly could be a value to look at, especially including other geographic areas in the United States. Now, that being said, the 50 least affluent neighborhoods or zip codes were generally areas that were urban and conceivably closer to medical centers, kind of paradoxically. And the 50 most affluent areas were suburban, but we can't really comment about too much. Regarding delays of care, again, we don't have that granularity, so we can't make those comments about that, but that certainly could have confounded our results one way or the other. With respect to the specific procedures, this again was not the intent of our study, but certainly could be the focus for future studies. The database unfortunately does not give us granularity in terms of whether these operations were open, if they were minimally invasive, if there was a conversion from a minimally invasive to an open procedure. Now, lastly, about the questions about the ACS or EGS services, don't know which specific hospitals these patients were admitted to and subsequently couldn't really trace to see which capabilities or services those patients were available.
Question from the audience.
Yes, Mike Edwards from Mayo Clinic in Jacksonville. Great presentation, very important topic. So one of the limitations, of
I don't know the answer to that question.
Okay. And I guess I would also quibble with where you live matters. I would say that implies that if we simply moved the people in the least affluent neighborhoods to another neighborhood, their outcomes would change.
So this concept of where you live matters kind of comes back from a lot of the public health literature that is out there. And what it really corresponds to is the different aspects that they have. So basically, do they have access to grocery stores? Do they have access to transportation? Do they have access to medical care? And really, it's more of a consistent pattern. Simply, it's not. I understand what the concern is, because it's not, one thing that you can move from one zip code to another, and then all of a sudden your healthcare outcomes and metrics will change. So I can certainly agree with that. With that statement. But again, I guess it's more trying to emphasize that there's a concept of the social determinant of health.
I just object a little bit to the simplification that it's where your butt sits is okay. So, but I think, we all understand it's who lives in that area, not necessarily, local pollution or whatever. So another question from the audience.
Actually, not a question. I'm New York name. I worked with Nefpreet. Just to answer your question, there's like another 200 zip codes in Maryland. We looked at this specifically because at the Bloomberg School of Public Health, they talk about predicting an individual's age simply by their zip code. And there's a 20-year difference in mortality if you live in the city versus if you live in the like the more suburban areas. And so we looked at this and didn't really look at everybody, but the plan is to kind of expand it and look at the rest of the states. But just simply by your zip code, they can predict how long you're going to live in Maryland, which is very interesting.
Oh, yeah, I mean, you can predict your income, et cetera, et cetera. So, yeah, very good. Any other questions from the audience? Thank you.
Thank you very much.
So we'll invite our final speaker, which is Charlotte Kirk. She's a third-year medical student, and she will be presenting on obstetrical trauma, reducing the burden of trauma transfer to tertiary care centers. She'll be coming from Maine Medical Center.
Okay. So thank you very much. My name is Charlotte Kirk. I'm a third-year medical student at the University of New England. I want to thank the Southeastern Surgical Congress for inviting us to present our manuscript today on obstetrical trauma. This research was completed at Maine Medical Center in Portland, Maine, in collaboration with the University of New England. Okay, so when starting our research, we found that the vast majority of traumas during pregnancy are minor. However, up to 70% of those traumas can still result in a fetal demise. We also found that major traumas are associated with a 9% maternal mortality and an 80% fetal mortality if the woman presents in shock. The literature suggests that the best predictors of poor fetal outcome are traumas occurring in the second trimester of pregnancy, placental abruption, high maternal injury severity score, necessity to perform an emergency cesarean, maternal fluid requirements, and increased maternal face and abdominal AIS. So once we learned what puts the fetus more at risk, we wanted to know how the literature recommends we monitor those patients. So they suggest that the most accurate representation of fetal status is electronic fetal monitoring, and that ultrasound, although it has a low sensitivity, it has a high specificity for diagnosing placental abruption. And also the KB test is the best predictor of fetal maternal hemorrhage. So in our rural state of Maine, there's only one level 1 trauma center, and the transfer of all OB patients in this state to that one hospital can be burdensome to both the patient and the hospital system. These transfers tax the availability and allocations of resources, as well as displace pregnant patients from their family and support systems. And not only can these transfers be challenging emotionally for patients, but also financially. So our goal was to potentially reduce that burden on both the patients and the hospital system. And we aim to do that by identifying both maternal and fetal indicators that would warrant transfer to a level 1 trauma center. So we performed a retrospective 5-year review of obstetrical trauma patients that were admitted to a rural state level 1 trauma center. To meet inclusion, patients had to have been picked up by a trauma registry and had to have been currently pregnant. So the data we collected was patient demographics, injury characteristics, maternal and fetal outcomes, ISS, AIS, GCS, frequency of fetal monitoring and ultrasound use, and the average maternal and gestational age. So we took that data and we analyzed it to see how it impacted uterine compromise and irritability, the need for cesarean intervention, and fetal demise. So this is just a snapshot of some of the demographics that we collected. I just wanted to point out a couple of things here. So the average gestational age in our patient population was about 28 weeks. So right on the cusp of the second and third trimesters of pregnancy. The mean ISS was about 4, the mean GCS was about 14, and the mean shock index was about 0.7. So most of our patients were not severely injured. Because this is a presentation on pregnancy, we just wanted to point out that about a quarter of our patients experienced an abdominal injury. But also we wanted to show where patients went once they got to the ED. And exactly 2/3 of our patients actually were just sent up to labor and delivery, meaning they were not hurt enough that they needed more care than that, and they could have been safely monitored up on the L&D floor. So this is just showing some of the complications that our patients experienced that were related to their pregnancy. As you can see, the most common complication was uterine contractions, and that still only happened in about 15% of our patients. And then ultimately, the vast majority of our patients were sent home after this admission. So that's 83% were able to go home safely. Of note, we did have one maternal death with a fetal survival, and we had 2 fetal demise. So through the analysis of our results, we found that a high ISS and a low GCS increased the risk of maternal mortality and blood product utilization. The low maternal GCS is a positive predictor of fetal demise, placental compromise, and premature rupture of membranes. We found that abdominal AIS was statistically correlated with premature labor, that a high maternal ISS and increased gestational age showed a higher rate for same hospital admission cesareans, and that the greater the gestational age, the greater the risk of uterine contractions following a trauma. So we had a couple points of discussion here. So one of them was, as I mentioned, the ISS for our population was about 4, which is well below the threshold of greater than 16 for predicted high mortality risk. So we sort of surmised that these were minor traumas that our patients had experienced. In the 2 cases of fetal demise, we wanted to point out that the maternal ISS in the first case was 5 with a GCS of 3. And in the second case, the maternal ISS was 15 with a GCS of 15. So that's sort of suggesting that fetal demise is at a higher risk when there's a low GCS and or a high ISS. The next point of discussion is gestational age. So as I mentioned before, we found that premature labor was associated with high abdominal AIS. And we also found that the greater the gestational age, the higher the risk of uterine compromise. And I also did want to point out that the 2 cases of fetal demise we had were at 36 weeks and 30 weeks gestation. So we believe these results highlight the risk of injury to the fetus after the 2nd trimester, possibly due to the height of the uterus above the pelvic rim. And the last discussion point was about fetal monitoring and ultrasound. So we found that our patients were monitored according to the guidelines that I presented at the beginning of this presentation. So 96% had fetal monitoring, 2 showing D cells and 7 with contractions. 94% had ultrasounds, 4 showing fetal placental compromise, and a total of 7 patients were taken for emergency cesarean. So we know that ultrasound predicts about 20% of 24% of placental abruptions. And like I said, it has a high specificity for placental abruption. We also know that fetal monitoring for a minimum of 4 hours showing 8 or more contractions is 100% accurate in predicting placental abruption and fetal compromise. So we think that our data reinforces the idea that it's important to monitor patients with both fetal ultrasound and fetal monitoring. So in conclusion, we'd like to say that in the event of a minor trauma, if the mother is physiologically stable and the fetus is not showing any signs of distress, that those patients can be managed at a community hospital without requiring transfer. We think resources available should include at that community hospital, the ability to perform fetal monitoring, ultrasound, and biochemical assessments for maternal fetal violation of circulation, such as the KB test. And if they don't have those resources, that a transfer agreement should be in place if they have positive risk findings. So thank you, and I'll take your questions.
Thank you very much. We'll invite Dr. Parker, who from UAB to be a discussant.
Yeah, hi. Thanks to the Southeastern Surgical Congress for the honor of discussing this manuscript, and congratulations to Ms. Kirk and the rest of the authors for their timely work on obstetrical trauma. I can say, you know, if you are anything like me, this deals with 2 of my least favorite things in the trauma world: pregnant patients and transfer patients. So all in one manuscript, and I'm happy to review. But I think it highlights some of the challenges in both the clinical care and research in this area, namely that these patients are rare, you know, as the authors highlight in their manuscript, with only 47 patients in their study over this 5-year period. This made up only 0.3% of patients that they evaluated, so incredibly rare for them in their state. And with that, I think it makes it hard to draw a lot of firm conclusions about the maternal outcomes, given the relatively low injury severity and low abdominal injury severity that they highlight in their manuscript. The other challenge that I think it poses is mainly related to the fetal outcomes, which as you identified were varied, including the need for 7 C-sections and 2 fetal demise, despite really pretty low injury severity on average for the whole cohort. And so I would ask, in line with the author's goals of evaluating these patients and their need for transfer, what differences did you observe between the patients that were transferred into your institution and those that presented directly from scene? Were there differences in injury severity, and were they transferred for trauma care specifically or for obstetrical care? Because if your transfers are anything like our hospital, they may be transferred to our service, but it's because they don't have the subspecialty that they actually want them to be evaluated for at their hospital. And then second, and somewhat related questions, do you know, what were the differences between the patients who required C-section or had changes in exam or their monitoring? What were the differences in characteristics between them and patients who had good outcomes who didn't need C-section? Thank you again for the opportunity to review your manuscript and to the Southeastern Surgical Congress.
Thank you for your questions. So to answer your first question, what were the characteristics of the patients that were transferred and how many were transferred in for trauma versus OB care? So overall, we had a low ISS, the average of about 4, and a high GCS. So like I said, the majority of our patients were not transferred because of their injuries. A lot of our patients were transferred because they were pregnant. Some weren't necessarily having obstetrical complications, but the outside hospital just felt uncomfortable managing those patients because they were pregnant. And your next question about those requiring cesarean, were they more injured than those who did not require cesarean delivery? I actually don't have the exact severity of those injured and those who had C-sections because we were really just looking at averages and then outcomes. So that's definitely a point of interest of us, and we'd like to go back and take a look at that. Like I said, there were only, and you said there were only 7 cesarean sections included in our study, and we just didn't do a specific analysis on that. Yeah, I think that answered your questions.
Lindsay Preya, Penn Medicine, Lancaster. Great job. Just 2 questions. You said that there were about a quarter of your population that had abdominal trauma. I'm just curious if you know of that subset of patients, how many of those went directly to the operating room? And then my other question is, one of your fetal demise patients, the ISS was 5, which would mean that they're not severely injured, but they had a GCS of 3, which just seemed kind of discordant. I'm just wondering if you could comment more if there were intoxicants or other things that were attributing to the GCS.
Yep.
Thanks.
So for your first question, I'm so sorry. Do you mind repeating your first question? Okay, so all of those injuries were blunt, and I actually don't have the information about those specific injuries and if they ended up going for cesarean, but we could definitely look back at that and address that in future studies. And then, so that patient that was a maternal demise that had the GCS of 3 and the fetus did survive. So they had a fatal head injury. So that's the only place that they were injured. And they came in with a GCS of 3, and it was decided that they couldn't resuscitate the mother, but the fetus could. And so the fetus was taken for cesarean delivery and the fetus did survive.
I have a couple of questions. You know, Maine's a pretty long state. Transfer distance, I would think, would have some influence on patient outcomes. And so do you have any information on transfer distance?
I don't. We didn't look at that exactly, but I can tell you that it could take up to 8 hours to get up and down the state of Maine just in an ambulance. So that is something interesting that we could look at in the future as well.
And I think the question I was about to ask was answered. And this was all blunt trauma, or were there
All blunt.
gunshots to the leg, or?
Nope, there were no penetrating traumas in the study.
And then when the patients were sent to L&D, I'm going to presume that those who had monitoring had decelerations. Were interventions done because of this, or are they, what interventions were done in L&D other than just simply, ho hum, everything's okay. 3 hours later, yeah, everything's okay. Were there any interventions to arrest labor?
We didn't look at that specifically. That, like I said, we only had a few cases where there were changes in fetal monitoring or problems on fetal ultrasound. But we just didn't look at the specific cases. But that's some point of future research for sure.
Alan Moore.
Alan Moore from New Orleans. I would encourage you to relook at that ISS of 5 with a GCS of 3. A GCS of 3, if you said it was a fatal head injury, their AIS may have been 5, but that automatically gives a GC or a ISS of greater than 15. Okay, so I would ask that you have your registrars recalculate that for you.
Okay.
Because those two don't go together.
Okay. Thank
Okay.
you.
Okay, nicely done and on time.
Thank you.
So we have a break now. We'll reconvene in this room in 30 minutes. We still have 2 more sessions today and then the business meeting at 5:45.